Great. Good afternoon, everyone. Thanks so much for being here. Welcome to the Nerve Lecture Series. Today, we're really fortunate to be joined by Dr. Matt Bush, who will be giving his talk entitled Prioritizing Health Equity in Otolaryngology. Dr. Bush is professor and chairman of the Department of Otolaryngology, Head and Neck Surgery at the University of Kentucky. Just letting a couple people in here. He completed his medical degree at Marshall University School of Medicine, followed by his residency in otolaryngology at the University of Kentucky, and did his neurotology fellowship at the Ohio State University. He also completed his PhD in clinical and translational science, as well as his MBA, both from the University of Kentucky. Dr. Bush serves as PI on several NIH-funded community-based trials that promote hearing healthcare access and utilization among underserved populations. He also directs the university's Kenya Outreach Program. We're really fortunate to be joined by Dr. Bush today. Thank you so much for sharing your time and speaking with us. And with that, I'll hand it over to you.
Great. Thanks, Josh. It's an honor and privilege to spend some time, connect with you guys. Hopefully have some time for some discussion here at the end. I'll try to be timely and move things along. I'm going to talk about a topic that's near and dear to my heart, addressing health equity. And just to fast forward, the reality is that I don't have it all figured out. I realize after 13 years of trying to do some research and describing, defining, and trying to address disparities, I feel like I've only scratched the surface, but it's a pertinent topic, and there's lots of academic opportunities here, but more importantly, societal and policy changes that need to be made that we can all play a meaningful role. So these are my disclosures. I've been a consultant for some of the industry companies that we work with closely. I don't have any off-label treatment I'll be discussing. I do have NIH funding through a variety of different grant mechanisms that's helped to support some of this work that I'll talk about. I want to start with just giving you a sample of a patient scenario that's real, that really impacted my life. I want to describe the tale of two 4-year-olds. The first 4-year-old is a patient who's actually been in my practice here as I've been a faculty member. But this is a 4-year-old female who's from Lexington, Kentucky area, the central Kentucky region. She's healthy, was born healthy, but she referred in both of her ears at a newborn hearing screen. At 3 weeks of age, she had diagnostic audiologic testing, which demonstrated significant, profound hearing loss in both ears, had a very early connection with audiology and speech language pathology, with hearing aid access and speech therapy. Continued in that care, and then at 6 months of age, we had done further diagnostic testing with repeat ABR, and as well as MRI imaging. The diagnosis was reconfirmed. The cochlear anatomy was normal. Subsequently underwent bilateral cochlear implant surgery, did very well through surgery, and then continued with her speech therapy and audiology appointments, even during the COVID era, through some telehealth support. And this 4-year-old's got robust speech development, and this is a child who's headed to K-5 next year. Is really just a success story. This is kind of one of those high five situations where everyone feels good and feels happy about this child that continues to make great progress. Unfortunately, that doesn't describe a lot of the patients in our clinic. We have many who have a very different story. And this next 4-year-old was a patient that I saw when I was a resident in otolaryngology here at the University of Kentucky that really impacted me in a significant way. This 4-year-old is a male from a very rural Kentucky community. He actually lives in a county where there are no healthcare providers of any type. He does not have an urgent treatment center or even a pharmacy within his county. Was born in an adjacent county, which is the only healthcare facility in the region. He was born full term. He was healthy at birth, but referred in both his ears by the newborn hearing screening test. Notice that he followed up for his first diagnostic test at a regional state-funded hearing healthcare clinic at 3 months of age. And as he was scheduled for this, they had to cancel the appointment multiple times due to transportation problems, and even presented at the first visit at 3 months of age, and was unable to sleep because didn't receive the instructions, was not sleep deprived prior to that ABR. 3 months turns into 4 years, a series of bumbled scheduling problems and challenges, as well as local providers to try to open doors and connect them. The child had been labeled with all types of, titles of autistic or cognitive delay or decline. And the reality is that this is a child who just hadn't had adequate diagnostic care. So at 4 years of age, presents to our clinic, and we found that this child had profound sensory hearing loss in both ears. And, it's just like, when I saw this child as a resident, I mean, it hit me like a ton of bricks. I mean, it impacted me as a person, as a father, as a clinician. And the reality is that this child has not had, any diagnostic testing, certainly not had treatment, and speech development is appropriately and expectedly delayed, and really behind the 8 ball. So, when I consider these kind of situations, these patients, these differences between these two, I think about the equity that we face and the inequities that society, sees in a lot of ways. Um, I don't know if anybody's on the line here. If you can hear me, if you can mute your microphone, there's some feedback, whoever that might be. Just help a brother out and mute your mic if you're not don't have something meaningful to chat with. So for every patient, how can we get them what they need when they need it? That's the biggest challenge that I think about this, is that we have, we owe it to every patient that we see to give them exactly what they need and when they need it. But that is a really tall order and, seemingly impossible. So what do we do to try to make our programs, our providers, our services more accessible, and improve the utilization of these services? There is a pervasive problem that health inequity, has affected otolaryngology and has been very persistent in the field of otolaryngology. And the inequities that we face in otolaryngology are rooted in real world problems. They thrive in the complex scenarios. Why does this matter? Well, it matters because we really, we talk about patients come first and patient-centered care is a priority. I mean, do we really believe that? And so there's a mismatch between what we talk about and what we put on our mission statements and on our web pages, and then what we actually practice. There is a priority, and this is obviously going to be connected to, our payment and reimbursement moving forward, that patient-centered care is what's going to be rewarded and funded moving forward. How do we define patient-centered care? Well, it's a holistic view of a patient's health, circumstances, and well-being in an effort to meet each patient's goals and needs to maintain or improve their health. So the challenge is trying to keep the patient at the center of this when we're dealing with these complexities and these pervasive inequities. This monograph from the Robert Wood Johnson Foundation is helpful because, as it not only defines patient-centered care, it takes a holistic view at, like, where are we really failing? Where are we dropping the ball? And there's 4 different concepts and topic areas that I think we really struggle with. One is inadequate information on the patient's perspective, that they don't perhaps have the information that they need of how to get care, where to get care, what's the process of care delivery. Furthermore, there's a lot of trust issues. And when I think about trust, we often use terminology such as, well, a patient doesn't trust me, or they have a lack of trust. When in actuality, I would advocate for us using even just a slight change of that terminology to trustworthiness. The issue is healthcare and our healthcare providers trustworthy? Have we demonstrated to a marginalized, dismissed community that we are worthy of their trust, that we're not going to use and abuse that trust? And so that continues to be an issue that fuels the fire of inequities and continues to propagate this problem. There are challenges in organizational culture and clinicians' training and beliefs regarding what patient-centered care really is. Sometimes we think about, look, I'm on time, and I went into the room, I gave the patient exactly the standard of care recommendations. That is patient-centered care. I gave them the right treatment. When reality, there might not be the right type of interaction, the right ability to communicate, just the way that certain patient encounters are set up that really kind of disadvantage us to deliver equitable care. Lastly, there's an alignment challenge of incentives and other factors from an external environment that complicate our ability to focus on patient-centered care. We get paid in volume, RVUs. The more RVUs, the better. But that's a disincentive to being able to take the time that might be needed with those that may lack an understanding of what hearing loss is or what a vestibular schwannoma is and how it's treated. So there's four main areas that I'm going to talk about during this presentation to just help us maybe realign and think about how could we, with a lens of equity, in perspective, how can we make patient care more centered on the patients themselves and focused on their needs? One, we have to think about the context that patients find themselves in. We have to think about connections that patients are either not connected to the system and providers, or they are. What's the culture, the way that we deliver the care, and how do we work on just seamless coordination of care? So these are some concepts I'll address during this presentation. So here's some big objectives in helping us to do that. As I've kind of laid the groundwork, I want to help us identify challenges and complexities of inequities in otolaryngology, specifically within otology and otolaryngology, but then evaluate research methods to help address inequities through community engagement. And then lastly, to discuss how pragmatic clinical trials can help promote equity in otolaryngology. This is a monograph from the American Public Health Association entitled Creating the Healthiest Nation. And I really like this because it helps to address this concept about responsibility and equity and, whose responsibility is it? And it outlines 5 different concepts about, how do we make equity a personal issue? And maybe this is not your passion project or what you feel your calling is, but there's elements of this that should resonate with us as human beings and help tie into why we went into medicine to begin with. One of the concepts is to be explicit, and that means to just call it as it is, define disparities in very clear and simple terms. And that's really important because as we believe with the medical record, if we didn't document it, it didn't happen. Certainly that's true in a court of law. If there's no record of that, then, it may never have happened and we can't prove that it did. So we need to be explicit to demonstrate that disparities exist in certain populations, certain types of services, and defining those. We secondly need to take a deep dive and understand some of the causative factors and some of the mechanisms in which these disparities originated and how they continue to be pervasive in the field. Thirdly, we need to create a culture of equity that involves not only in how we conduct the research, but the team members, a part of our research teams and academic institutions, but then of course with patients and their communities. We need to respect and involve communities in research initiatives and in initiatives that are focused on expanding access and utilization of care. And then at the end of the day, we need to measure and evaluate whether we're making any difference. And that's not just going to be on a provider or researcher perspective. That's going to involve the community and those individuals most affected to be able to tell us, are we, moving the needle or perhaps even just removing the needle at large? So when you kind of summarize who's responsible for equity, well, a simple, answer to that question is you. But I'm going to use a Kentucky phrase to answer that question, that who's responsible for equity? It's y'all. And if I'm gonna get really Kentucky or West Virginian, which is my roots, it's all y'all. The truth is that it is our responsibility to take this seriously and think about these concepts as we frame equity. What causes inequity? Well, there's lots of complications and lots of challenges. Maybe there are some biological reasons in which there may be certain populations that may have a higher incidence of a disease or greater difficulty with access. But we know that the biggest impact factor of why these inequities continue is because of differences in populations in these social determinants of health. These are these 5 different domains that you maybe remember from medical school, may not play a major role in your day-to-day clinic or in your surgical planning or skull-based operations, but every patient is impacted by these 5 domains: education, social community context, economic stability, the neighborhood or the physical environment in which people live, and then the healthcare access and quality. All these are concepts that are critical for us to understand. And the reality is we've begun to scratch the surface in understanding some of the impacts of these determinants on health in otology and neurotology, mostly around healthcare access and quality, a little bit in education, perhaps also a little bit in economic stability. There is a great open door of opportunities to understand how social and community context affects decision making in cochlear implantation, for example, or in how patients pursue treatment or lack of treatment in vestibular schwannomas. Also the neighborhood and built environment and how the environments might influence or propensity for hearing loss and make it more difficult perhaps to access care. Again, as I talked to you initially to set the stage about some of these concepts I'll discuss from the patient-centered care concepts, context really matters. So I'm going to tell you a little bit about my context. So I practice here in Lexington, which is shown by the star on this map to the right, here in the central part of Kentucky. And we are the main providers for the Appalachian region of Kentucky. So Appalachia is not a region, where you can just, hear the deliverance music in the back of your mind. Appalachia is a pretty diverse region that actually involves about 8 to 10% of the U.S. population geographically, that stretches from New York all the way down to Mississippi. Within this region of the country, there are urban centers like Pittsburgh. There are very rural regions. And you can see on the socioeconomic heat map that some of the most socioeconomically depressed counties in Appalachia and in the U.S., for that matter, are in the eastern third of our state. So about 25% of Kentucky's population live in the Appalachian region. UK's campus is actually in Fayette County, which is not an Appalachian county, but just a county or two adjacent to us begins the Appalachian region. Many of these counties in eastern Kentucky have faced, the aftermath and the shock waves of the opioid epidemic. Thousands of people lose their life every year because of opioid overdose and abuse. Many of these counties also have been labeled as persistently impoverished, and that is a title that you do not want your county to have. That's defined as 40% of the population within the county below the poverty line for 40 consecutive years. That represents generational poverty that influences education and lack thereof, as well as life expectancy, which is, you might guess, low. There's also a coexistence of these pervasive chronic diseases such as diabetes, heart disease, cancer, and these big 3 diseases often take up the majority of the healthcare resources and healthcare interactions, with a lot of things, perhaps non-threatening issues like a hearing loss, to be dismissed. So it's in that context that I, and especially as I experienced some of these patients, like that 4-year-old as a resident, that made me begin to ask questions like, okay, I know we serve this, we're kind of a safety net type of center that provides care for indigent populations, marginalized, dismissed rural populations. And that's where I began to ask some scientific questions. What are some hearing healthcare disparities? Does this exist? And I started, initially looking at a pediatric population. Um, so I'll talk first of all about, defining some of the evidence that is out there to describe some pediatric hearing and hearing healthcare disparities. This is one of our first publications when I came back after my neurotology fellowship. I just wanted to put a stake in the ground to just say, hey, is there a difference between rural and urban populations in the diagnosis of pediatric hearing loss? So we partnered with the EDDI system, that's the Early Hearing Detection Intervention Program here in Kentucky, which is actually pretty robust and has been tracking the data for a really long time with pretty high efficiency and effectiveness. The challenge is actually getting the children to do the screening or to do the follow-up diagnostic testing. It's a challenge. But we've looked at our state data and found that rural children are more likely to no-show after a referred newborn hearing screen compared with urban children. When we further drilled down to look at our children in our institution, we found that the actual timing of diagnosis, because of this lack of timely follow-up, resulted in rural infants being diagnosed with sensorineural hearing loss at about 7 months of age versus 5 months of age. So this paper from the Journal of Pediatrics was really a first paper that defined that there is a difference in pediatric hearing healthcare in the timing of care based on rurality or their geography. A follow-up study began that we partnered also with the EDDI program in the state is to try to target where might there be higher incidence regions or pockets of hearing loss. And we use a geospatial scan to be able to evaluate these regions of higher incidence. Notice that that eastern third of the state did not have overall higher incidence of infant hearing loss. We actually found a very high incidence region in the westernmost part of the state, which, even though it's not Appalachian, it's a very rural Midwestern farmland type of environment where it's pretty flat, like a lot of the Midwest, but also very far away from a lot of services. And so we had an incidence of infant hearing loss of 7 out of 1,000 live births. We don't know the reason for this, but the challenge is that even though there's birthing hospitals in the area, there is a lack of cochlear implant centers. There is a lack of specialized pediatric hearing healthcare services within that region. So doing this type of a study, even though it didn't necessarily confirm that Appalachia has this problem of higher incidence of hearing loss, we know that the whole rural region is less likely to follow up. But we see a mismatch between where the disease is higher incidence and where there's a lack of services. So that's why this kind of study was an important next step for us. A subsequent study looked at the timing of hearing healthcare important time points for those children born with severe sensorineural hearing loss. And rural children essentially took 2 times longer in this study compared with urban children to get hearing aids and 2 times longer to get cochlear implants. And we described this using a Kaplan-Meier depiction here, and this defined and basically showed that the average cochlear implant age for a child with sensorineural hearing loss in a rural community was 4.7 years versus about 2.4 years. And this was really a validating moment, a validating study in my own mind and life, because it showed me that what I was seeing as that third-year resident, this child that's delayed, this is a real thing. And to be able to put this into print was an aha moment, and also really kind of pushed me to continue this work to say, all right, now that we've defined and described some of this thing, how else do we begin to figure out why does this occur and how might we address this? Things don't get easier after children are implanted, and those that live in rural communities have cochlear implants. Based on this study we published in 2018, we see that these kids have a longer distance to their audiologist or speech language pathologist. They're less likely to get connected with speech therapy prior to implantation, and they're also likely to have higher incidence of device problems. And as you might expect through a lot of similar type studies in pediatric populations, that parental education is very tightly linked with outcomes for children. So this is a study that just described further those complications and challenges that children have after cochlear implantation. This doesn't apply only to sensory hearing loss, but it also applies to rural populations and indigent populations that are on Medicaid and chronic ear disease. We've shown in a publication recently that we have higher no-show rates for children that are on Medicaid, and that's more likely to be a preoperative no-show visit, as well as higher incidence of post-op no-show visits, as well as a lower odds of having a post-operative audiogram. So, I mean, how do we know that this child needs hearing aids or not? If you're not getting audios, if you're not seeing them in post-op, then you're really not providing comprehensive otologic care for children with chronic septal otitis media. This study also demonstrated there's a higher rate of cholesteatoma in Appalachian children compared with those in the non-Appalachian region. So higher disease incidence, less likely to utilize services. It really creates a major, sort of a public health emergency. We've also tried to learn from our own experiences within our academic center with the pediatric populations. And, we've looked at all of our pediatric audiology appointments based on different appointment types over the last, over a 2-year period. Overall described the 24% no-show rate. Those that are the highest risk to no-show were those of younger age. Those of African-American race had a higher no-show rate. Medicaid insurance also higher. An audiogram over other types of specialty appointments were more likely to no-show. And then also in at least our state, summer was the period of the highest no-show. So why is this important? Well, how can you begin to make changes in the way that you schedule, the way that you deliver care, if you're not really aware that there is a problem or when there might be a problem? This Kentucky is a rural state. Farming is a big part of many rural communities. And there are many families that are working together during summer, perhaps during early fall in some harvest seasons, and it influences their ability to access care because of just the workload that may go on in some of these communities. So we have to take all of this into context when we begin to frame disparities and try to understand how care is utilized. Now, this isn't data here from Kentucky, but this is a demonstration that, we have to also understand that just besides geography or socioeconomic status or insurance status, there are racial and ethnic issues in relation to disparities. Cedric Pritchett published this paper a few years ago that described cochlear implantation in Florida, and then their review of 12 years worth of data, they found that no Black child was implanted younger than 12 months of age. Furthermore, if you looked at children just being implanted by the age of 2 as an outcome, there was less likely to occur for those that were Black, those that had Hispanic ethnicity, and those on Medicaid insurance. White children that were self-pay or white Medicaid children are more likely to get a cochlear implant by age 2 than privately insured Black patients. So Cedric's paper really defines and demonstrates that there is racism in cochlear implantation in the pediatric populations. So let's shift gears a little bit. I'm going to define some adult hearing healthcare disparities now too. So this is a figure that Ashley Nassiri put in a publication recently with collaboration with Matt Carlson as they describe barriers to adult cochlear implantation in the United States. And I think this is a really informative diagram because it does describe kind of the Beatles song of a long and winding road, considering that there is a long journey from a patient beginning to identify that, yeah, I think I have a problem, or listening to their family that they have a problem, and moving through the healthcare pathway as their hearing loss may or may not progress to actually receiving a cochlear implant and establish care. There's a lot of challenges and a lot of barriers that one might face, and it begs a question, would you seek hearing healthcare if you knew you had to do all of these things. Perhaps as a fellow, maybe you're thinking like, I'm not sure I'll get to see the dentist this year, or even see a primary doctor, definitely not take a day off. So, in our busy careers, we think about how we might access hearing healthcare would be perhaps very different than these patients. I drew a red circle around these couple areas because these really represent some key transition points from patients having an awareness that they might have a problem to actually being seen by an audiologist for a diagnosis. That is the entry into hearing healthcare. That is a real opportunity area for us to study and us to address. And I'll talk to you a little bit later in the presentation about how we might, through perhaps research, pragmatic trials, be able to promote a better access, an entry into hearing healthcare. The second arrow to the right represents this transition from hearing aids into cochlear implants, and where are there opportunities to help those patients not be lost or not be lingering in this holding pattern of hearing aids that aren't adequately helping them, and maybe moving them forward if they're appropriate candidates. In the adult population, we've published a couple studies looking at hearing aid recipients, as well as in cochlear implant recipients I'll talk about on the next slide. But this shows a difference in the timing of that journey through that long and winding road, from that self-identification of hearing loss to actually receiving a cochlear implant, to receiving a hearing aid. Rural adults have about a 26-year journey in that that process, whereas urban adults have about an 18-year journey. Some of that may be related to shortages in audiology in rural communities. We see a similar pattern in cochlear implant recipients, that from the self-identification point to actually receiving a cochlear implant, a 36-year journey to a 29-year journey in urban populations. So rural residence and geography makes a difference on the timing of these key moments of receiving a hearing aid and receiving a cochlear implant, just like we demonstrated in the pediatric population. There's a number of sociodemographic factors that, has been demonstrated by, several groups, some even represented on this call here, involving populations in Texas, Georgia, South Carolina. But there's evidence of lower likelihood of pursuing a cochlear implant for even an evaluation in non-white populations, those that are older, those that perhaps lack a social support system and may be single or widowed. We also see, not only from the moment that they know that they're a candidate to actually receiving cochlear implantation, there's delays in that part of the journey for those that are non-white race. And of course, Medicare continues to be a barrier for lots of different services, receiving a second side cochlear implant, you name it, there's plenty of barriers that insurance can set up. So I've summarized a variety of these different social determinants of health domains and some of the pertinent findings to some of these domains in a couple publications, both in ear and hearing and in seminars in hearing. So I'll refer you to those papers if you want some light reading about some of these public health challenges. So now, how do we pursue equity? What do we do about this so we can understand some of these mechanisms, some of these things that are at play in these defined disparities? Well, one concept that I want to present to you is that we need to promote equitable recruitment and reporting. We need to do better research, okay? So the methods and the reporting of what we do needs to really embrace equity. There's a couple concepts that two papers help to bring home regarding that, is that we need to change the culture of the research in our recruitment and reporting. Carrie Neiman and her group, with the first author, Corinne Pittman, published a systematic review about hearing related trials and research, and found that recruitment in those trials was inequitable, that the gender recruitment as well as racial and ethnic group recruitment does not reflect the population. And so this is something that needs to be addressed in how we conduct the research, that it should reflect our population, and how we actively, try to bring in certain populations or a makeup that would reflect, what represents all of us. In a systematic review that our group published, we just looked at cochlear implant trials, and commented on whether sociodemographic information was provided. So basically, did the trial involving a cochlear implant, prospective, randomized, whatever the design, but it had to be some type of interventional prospective study, did they report race, ethnicity, socioeconomic status, education, insurance, geography? And less than 10% of these cochlear implant trials report this key information. Gender would be the most commonly reported factor, but these other issues are largely ignored. So how can we know who we're even studying if we don't even describe this? So we need better reporting of this kind of information for our trials. We can also promote equity by building trust with patients. Remember, I talked about this concept of trustworthiness and the inadequate trust within the health system. This is a study that we had done as a part of kind of a quality improvement project to evaluate time spent in a room with patients. And this particular study demonstrates some interesting things that we found. I'm bringing up this concept that time matters. If we have little time with patients, we make little impact. In this study, we had basically looking at the average time. There was 8 minutes of MD physician time with patients with hearing loss. 8 minutes, and you think about their 26-year or 36-year journey to receive a hearing aid or receive a cochlear implant, and they get 8 minutes of our time. Patients that came to just see a generalist or a general otolaryngology, comprehensive otolaryngology clinic, those that were spent with hearing loss patients were 4 minutes less than those that had just some general complaint. And furthermore, when you look at when we're in teaching institutions, that as a resident learner is involved, often maybe a physician, attending physician may feel like, I don't need to do anything. They've kind of already set the stage. I just need to answer some questions and just get the heck out of there. And so as that resident learner time increases, that time with the physician decreases. So this is, an interesting issue. And you can see, that dizziness, for example, was shown by the circle or the oval on the left side. That's on average, at about 12 to 15 minutes. Whereas the hearing loss, again, right at about 8 minutes. So how can we be trustworthy if we don't spend time with our patients? Well, there's, again, this mismatch between what our compensation really values and pushes us towards. And so I'm not telling you to just, cancel all your clinics in its current setup and, maybe set up a neurology-like clinic where you see 6 patients a day. But I want you to consider, the time matters when it comes to health equity. Time is not the only thing that matters. Words matter. So what we do to provide information for the consumer about hearing healthcare interventions such as cochlear implants really is important. This is a paper we published recently that describes the readability of healthcare information regarding cochlear implants in publicly available websites, whether that's industry-sponsored, university-affiliated, or independent websites. Overall readability should be about a 4th to 6th grade reading level, but on average, the reading level is 10th to 12th grade. None of the 80 websites had information that was at the recommended reading level. Furthermore, that the quality that is put out on those cochlear implant websites is not accurate as graded by experts in the field. We see a similar thing in a paper that's just been accepted for publication in Journal of American Academy of Audiology, that hearing aid websites don't have that readable of information either, that it's only on a 10th to 12th grade reading level when it should be to 4th to 6th grade reading level, and the quality information is not that great either. I also would encourage you to consider, as we approach this from a research standpoint, how might we weave in equity into some research designs and methods? There are some research concepts, and I think this is an important slide as it relates to research methods in addressing equity. These 5 different concepts have been some guiding principles that have helped me in some of my grant writing and the current studies I'm a part of. First of all, mixed methodology is critical. I'll talk about each of these in just a moment, but mixed methodology means a mixture of qualitative and quantitative research. We also should be collecting these social determinants of health, as I've already alluded to in a couple slides prior. Community engagement is going to be an important issue. We also need to be involved in prospective, rigorous clinical trials that may involve a medical intervention or perhaps a behavioral intervention, and then incorporate dissemination and implementation methodology into research as well. So let me talk about mixed methods for a minute. So qualitative information is really important. You know, narrative input that comes from patients or from community members really matter. We can learn so much about some of the mechanisms of why these disparities and inequities exist. In a very practical sense, when we're getting this kind of information, it strengthens our quantitative randomized controlled trials. It may address appropriateness, acceptability, or feasibility of an intervention that we're wanting to test in this community. We might find that qualitative information may help us develop questionnaires or alter or adapt our recruitment methods to really reach out in an effective way into the community. And then we also can understand the mechanisms of the success. You know, if we do a quantitative trial and we don't get the p-value or the confidence intervals that we want for intervention, we think all is lost. But if you have woven in qualitative research as a part of your research, you may realize that there's a lot more behind the scenes, and you may understand why it didn't work or perhaps why it did work. Collecting social determinants of health information is helpful. These are a couple inventories or tools that could be used to assess some of these different domains coming from the National Association of Community Health Centers, as well as the American Academy of Family Physicians. Community engagement is critical. Every research lab should develop a community advisory board, getting people in the community, whether it's be patients or educators or clergy or community representatives or other stakeholders, perhaps, you know, politicians that may be able to communicate better the voice of the community, the priorities of the community. And we need to build trustworthiness of ourselves in the community. I have found that a community advisory board helps to establish this communication, builds this trust with potential participants. It helps us to get a common vision of priorities and protocols, the way that we're going to conduct the research in an equitable way, gives us shared innovation and success. They have brilliant ideas that really can make our research much, much better. And then we can find that after we've completed research, that we might be able to efficiently translate those findings back into practice, and that actually might make a sustainable change for health if we have this type of community involvement with the research agenda. We need to think about clinical trials as well. Susan Emmett and I, along with some of our colleagues, published a paper on describing how some different study designs can be utilized when health equity is at stake and trying to address an equity issue. Of course, randomized controlled trials can be an appropriate design. Cluster randomized trials also are very appropriate when you know, you want to intervene in different communities in different ways with interventions. In my lab, I've used a step wedge design a number of times where the different communities that are involved in the study will all receive the intervention, but just not at the same time. And so we launched the intervention on a delayed fashion during the course of perhaps a 5-year research grant. So there's not any one method that's right for all, but it is there's different ways to think about how we study the problem and design the study. I'll mention briefly a concept of D&I science, and D&I refers to dissemination and implementation. You can see from the definitions that are on the screen here that this is a newer field scientifically that helps us to, in a scientific, rigorous way, study the integration of evidence-based interventions, perhaps within a specific setting, in the case of implementation. Dissemination is a broad or a wider sweeping spreading of evidence-based intervention to a target population. Why is this important to study D&I science? Well, first of all, it's a priority to the NIH, but it's helpful in our translation of research. And we're dealing with messy real world problems that require us to be very practical about how we engage communities and how we're studying how an intervention could be useful or not. This is why D&I is important. We often find ourselves in research in the bottom left side of the screen, that we have a study, a pilot study about, a device or a behavioral intervention to promote, let's say, cochlear implant evaluations in a population. And then we may move to an efficacy study with one or a couple centers. And then maybe we have like 8 centers involved in an effectiveness trial. Maybe it works, maybe it doesn't. But often we go back to the drawing board, or things just stop there. D&I science can really move towards translation of research of an intervention that has evidence behind it, and then can move this towards population health and studying the new settings, how it's adopted in different environments, the process of how it's implemented, as well as how do we keep it sustainable in populations. Here's a question that may be of interest to you, of how D&I science could be useful in your research. If you're still trying to develop an evidence-based intervention, then you could understand how to adapt or implement, expand, scale up, sustaining. D&I science has rigorous methods and tools that can be used to evaluate and describe these different concepts. If you're gathering evidence still, you can actually do dissemination work and implementation work along with effectiveness trial. And that's called a hybrid design. That's some work that I'm currently involved in. The last concept I want to bring up is about coordinated care, about how we create novel-based team models to help us coordinate the continuum of care for the sake of equity, because many of these patients are lost in the health systems. In our center, we've developed a patient navigation program in which we have studied and developed a program where trained lay healthcare workers to provide some educational, psychosocial, and logistic patient support. Patient navigation comes out of the cancer field, and we've adapted it to try to address hearing healthcare disparities. And we developed this program in 2014. That was a part of my K Award. And the navigator is working with parents of infants who failed newborn hearing screens to try to promote the guidelines that a child should be screened no later than 1 month, diagnosed no later than 3 months, and have hearing healthcare intervention no later than 6 months, and trying to just reinforce that and support them as they make that process. And we published on the value of the patient navigator program and found that compared with the standard of care, standardized phone calls, that a patient navigation actually improves the follow-up rate from about 68% to 93%. And actually, it improved our timing of diagnosis. It dropped the days from 106 days after birth to 68 days to completion of the diagnostic testing. And some of the mechanisms we feel like is that a patient navigation is improving the parental knowledge in a very personally delivered way of the EDI goals and the responsibility to come back in for the testing. That is not adequate to change health. That's a publication. It's great. It's nice as a CV builder, but it doesn't necessarily move the needle or change anything. So this is what we're doing now is we're taking that navigation program and we've launched it into publicly funded hearing healthcare centers that are the state-run program in 10 different sites across the Commonwealth of Kentucky. And we're evaluating the effectiveness of the navigation to promote infant diagnostics and simultaneously evaluating the implementation factors as well as the cost impact on, does the lack of no-shows improve the cost effectiveness and the economics of the clinic, or is it a neutral effect? So this is an ongoing study now that we're in the process of completing. So, and it's just an example of how you can do this work with NIH funding to do work in the community, a pragmatic trial involving D&I science. Here's another example of a trial that we're evaluating, that patient navigation program actually for adults in rural health clinics and federally qualified health centers, in which we're We've done some exploratory work to kind of evaluate the barriers and the challenge through mixed methods in adults in these types of hearing, in these types of rural clinics. And now we're in the R33 phase, an intervention phase, where we're testing the same type of patient navigator program we've published on the pediatric population to see if we can take adults that are outside the hearing healthcare system and bring them into a diagnostic audiogram. And the last study that I'll describe here is another hybrid study that Susan Emmett at Arkansas and I are involved in which we're thinking about, new environments. How can we take, hearing healthcare into new places? We're studying in 14 rural Appalachian counties in Kentucky, counties that don't have healthcare providers primarily and don't have audiologists or otolaryngologists, but have schools, and to see how this hearing screening that occurs in the schools could provide better information. And we're trying to provide a telemedicine hearing solution that would allow us to evaluate the children through diagnostic testing and tympanometry, and then give that information to the parents through a cloud-based system, as well as to give it to local hearing healthcare providers to triage and to promote better efficiency and utilization of hearing healthcare. And meanwhile, while we're trying to conduct this trial in these 14 counties, we'll be evaluating implementation factors. So just another study that demonstrates our goal to try to implement some of these different designs, but also to try to move the needle forward. So I'll leave you with a call to action for equity. I'm encouraging you to define inequities as you see them, as you think about them, perhaps in populations that you serve. We know that these inequities are evidence across sociodemographics and influenced by the social determinants of health. We all are responsible to conduct equitable research and consider different data and designs and how we do this. And lastly, we need to incorporate novel models and methods to promote equitable and efficient translation of research to affect the broader population and broader groups of people. So we've reached the finish line. I'm very thankful for your time and attention, and look forward to any questions or dialogue that you've got.
Thank you so much, Dr. Bush. That was a really, really, really excellent talk. We appreciate your time. I think Dr. Prentice raised her hand here, and she has a question for you.
Matt, I always love listening to this talk. I think it's so important, and it's something that people don't really realize how much it impacts us. Have you noticed any change, with the use of telehealth now to reach those more urban areas or I'm sorry, rural areas? And is that increasing, do you think, access and equity?
I think that we are doing a poor job of how we are disseminating and implementing telemedicine. So this is where I think is actually a hugely promising area of this D&I science field is in telemedicine, because there's all these pilot studies, these feasibility studies, and we show that, well, patients think it's okay and providers think it's okay, but we're struggling with a lot of the infrastructure that are on the patient side. And we're also struggling where, let's say, patients have a device in hand, and on the clinician side, we question and we worry about the utility and the accuracy of the information that we're getting. So there needs to be more work in this field. So I do think that we're finding novel ways to communicate. I think COVID has pushed all of us, and at least certainly in the pediatric populations, children have had to learn how to do some type of school or instruction, remotely. And so I do think it's impacted children in a much more positive way through connection about cochlear implant care, let's say. Adults less so, and that's where I think there's just so many opportunities in the equity field.
We have a question here from Lena. I only see the first name there, but please go ahead.
Hi, I'm Lena. I'm the neurotology fellow. Really enjoyed your talk. I did a disparities research paper for vestibular schwannoma patients, and one of the findings, and I thought we had a pretty good like statistical model that we came up with, like incorporating the different domains that you talked about. And one of the things we found was that like men were more likely to have like post-op complications, specifically like CSF leak. And when I was trying to like submitting this paper for publication, people really like, I didn't really know how to explain it other than maybe just, maybe men aren't really following the post-op instructions as well. Or, I didn't really have it, I didn't try to explain, but I think some of the reviews really fixated on like, oh, why did that happen? And I feel like sometimes you may not be able to exactly explain why. And
Right.
I don't know, I kind of struggle because I really hear what you're saying about like actually looking to see if there's a problem before you try to fix the problem. And I felt like the reviewers were really fixated on why. So I don't know if you have any like thoughts or like
Yeah.
or like ways to approach this type of issue, or is that just like an issue in our field, or I don't know if you had any thoughts on that.
Well, first of all, research sucks, right? Research is hard. And
Yeah.
we have a hard time getting data, and like, okay, I recruit patients from my center. Well, okay, you're at a fellow for 2 years, so you recruited, let's say 40 or 80 vestibular schwannoma patients, but then you move on, and then who actually follows those patients for these complications? So it's like getting this data. So maybe you get a national database of all these vestibular schwannoma patients, and you don't know who the heck they are. You don't know how accurate this data is.
Mm,
We've got all kinds of confounding variables, and you say, all right, I've designed this study and I'm trying to then look for, let's say, medical comorbidities. Maybe men had a higher number of comorbidities, whether that's obesity or diabetes or whatever, had wound breakdown, CSF leak. But, you know, the reality is don't trash the data, don't throw it away, be honest, be open about what you find, and find a home for it, open access wherever. So don't allow a reviewer to stop you in the work that you think is necessary. You acknowledge your limitations, but just let the data stand. And if it's
mhm,
not publishable, it's not publishable, and then figure out a way to move forward. So then you say, all right, well, then I want to understand, like, I'm going to prospectively evaluate this population that I'm concerned about may have a higher incidence. I'm going to do a little deeper dive in, if you suspect maybe a mechanism is people aren't following instructions, like some kind of exercise log or some kind of activities. So you try to, do a study that would, dive deeper into what you think the perceived mechanisms are. That would be a
mhm.
way to deal with it. So again, don't lose hope. Get it published somewhere. I mean, we all have seen, we all are aware of open access. There is stuff out there that it doesn't seem publishable, but gets published. Lena, that's not your study. I'm sure your study is fantastic, but the reality is just, don't allow that to the complexities of trying to conduct the research keep you from your desire to pursue truth and ultimately get to some answers of why different patients have different outcomes. That's critical to like maintain that curiosity and that passion to find the answers.
Yeah, that's really helpful. I mean, I guess um yeah, I guess I was a little bit discouraged because I thought we had a pretty good model. We had worked with economists and other people to like make it really
Mm.
robust, but then it was like, why can't you explain this? I was like, well, I don't know.
Was
I
there
don't know
medical
this.
comorbidities that you accounted for, like a
Yeah,
multivariate
yeah,
analysis?
we did a multivariable variable analysis. We did comorbidities. We did everything. So, anyways, it was just, yeah, I guess it's really
It
only
wasn't
like
me,
one.
Lena. I didn't
Okay.
reject your paper. I would accept your paper, maybe with minor
Mhm.
corrections or revisions. But yeah,
Yeah.
I mean, reviewers have bad days. I mean, I have bad days. I mean, I'm kind of like, it's easiest for me to just reject this paper. Please give me some critical, error that I can just quickly hit reject and move on. And that's just
Yeah.
human nature, my laziness
Hmm.
on it, me being transparent. So don't let that
Got
hold
it.
you back.
All right. Well, that's encouraging. Thank you.
Dr. Bush, one of the things you brought up early on in the talk was just the concept of trust, and trust as a sort of source of disparities and inequity, and reframing that as sort of trustworthiness and perceptions of trustworthiness of the physician. And I was thinking about that, and also in the context of looking at the numbers of how much time we spend with hearing loss patients versus other types of patients within otolaryngology. And I was curious as to what are some of the things, strategies, either coming from your research or just in your personal experience as a practitioner, that you have found to be successful in building that sort of perception of trust, or legit trustworthiness as a physician treating patients who have been facing this level of disparity and inequity for such a long time?
Yeah, it's a great question. Let me just talk to you first about from a research perspective. There are lots of opportunities to explore this across a wide range of populations, and we need to be able to understand how to elicit some of the concerns and some of the reasons, the presence of lack of trust, as well as some of the reasons that it exists. If you look at otology neurotology, we don't publish qualitative evidence, and it's not for the lack of the editorial board wanting to publish on the topic. It's that people don't submit this type of research to otology neurotology. I'm gonna float a few qualitative papers that way. I'm on the editorial board myself, but we need it because we need to understand some of these factors, and I think we need to be able to read it and as clinicians and understand what it means in context of population health. So I would say that's something we need to do, is we need to do qualitative work of trying to understand from the community member, the patient's voice, why are there challenges, why they haven't sought out hearing healthcare, why they don't want to get a cochlear implant, why they don't want to do surgery for a vestibular schwannoma. As a clinician, I will say
Matt,
that.
can I pipe in real quick? I mean, I think that's a great point, and everybody who's a trainee on this call should really listen to that, right? I mean, because you might find, right, that like some of these papers may get rejected that have this qualitative, analyses in them, and because people don't understand them, they don't see the value. But your job as the next generation is like to push the field forward in the right direction. And like what Matt said is an amazing point, and I've kind of included in my studies as well, is that qualitative arm. You're going to learn, it enriches the data so much more, and it's going to give you the next idea, right? Or it's going to give you the idea of where that research should go next. So I kind of, even if kind of reviewers don't understand it, don't get it, keep pushing it, because that's kind of where we need to go and to mature our field. So
Yeah, preach it, brother. And this goes back to Lena's point, is that, like, don't let reviewers craft your research. Let health and let patients craft your research, and you do the right work, and it's going to be okay. But have smart people that are involved in it. You'll have reviewers read a qualitative paper, and they'll be like, well, was this an adequate sample size, and where's the p-values, where's the statistical analysis? And you're like, okay, you missed it. You don't understand what this is even trying to say, and that's okay. But we are involved. We need to be the generation that helps to move this forward. Not only qualitative work, but just a combination, that being mixed. I'll also say then to Josh, to the question about as a clinician, I mean, I want to push myself to be very empathetic, to be open, to ensure that I sit down with patients, that I do not touch a device or a screen if I can avoid it, that I really face patients, that I have a posture and verbal and nonverbal body language and expressions of an openness and an empathetic attitude in the way I care for patients, regardless of whether that's a physics professor on main campus here at UK, or if it's somebody who's a grandparent who's caring for their grandchild because their child's parent is incarcerated. Whatever that situation, I want to ensure that I'm pushing myself to be a qualitative clinician and that I really value the things that they say. I think there's a little bit of a holistic approach about embracing equity in not only how you talk with your MAs, but how you talk with your patients and how you're publishing the research. Practice what you preach.
Yeah, that makes sense. Thanks a lot. We're a little past 6, so I don't want to take too much more of your time, Dr. Bush. But thank you so much for that talk. I got a recording of it, so anyone who can't be here, I'll put it on our YouTube for all to see. And it's really helpful and really informative, and I really appreciate your time today.
Yeah, my pleasure. You guys keep up the good work. Feel free to reach out to me if I can help you in these issues. You want to collaborate, you want to communicate in any way, I'd be honored. So finish strong. Those of you who are fellows.
Thank you so much. Have a good night, everyone.
See y'all.